before you buy a bottle of magnesium because someone told you that 480 milligrams can reverse insulin resistance by 71%. Stop. Because that claim contains one piece of truth and one very dangerous misunderstanding. Yes, researchers found a striking 71% difference connected with magnesium, but no, they did not prove that taking a 480 milligram pill reverses insulin resistance by 71%. That is not what the study showed. And the difference matters because magnesium may help some people significantly, do almost nothing for others, and become dangerous in people whose kidneys cannot remove the excess. So the real question is not, should everyone take 480 milligrams? The real question is, are you one of the people whose insulin is struggling because your body is running low on magnesium? That is a much more important question, especially after 60, because insulin resistance can quietly develop while your fasting blood sugar still appears normal. Your pancreas may already be producing more and more insulin just to keep that sugar under control. Meanwhile, magnesium is involved in the cellular machinery that allows insulin to deliver its message. If magnesium is inadequate, that message may not travel as effectively. But here is where the story becomes complicated. Some clinical trials have reported improvements after magnesium supplementation. Other well-designed trials have found little or no improvement in insulin resistance. And in a recent trial involving older adults with prediabetes and low magnesium, supplementation lowered fasting glucose, but did not significantly improve insulin resistance or HbA1c. So magnesium is neither a miracle cure nor useless. The truth sits somewhere in the middle. It supports energy production, normal nerve and muscle function, blood pressure regulation, and blood glucose control. Inside the insulin signaling pathway, magnesium helps enzymes perform the chemical reactions that allow insulin's message to travel through the cell. That gives researchers a biologically plausible reason to investigate whether low magnesium could contribute to poorer insulin sensitivity. And there's another connection. People with insulin resistance or type 2 diabetes can lose more magnesium through their urine, particularly when glucose levels are elevated. That creates a possible two-way relationship. Poor glucose control may increase magnesium loss, while inadequate magnesium may interfere with normal glucose metabolism. However, possible relationship does not mean magnesium deficiency is causing every case of insulin resistance. It means magnesium may be one piece of the problem in certain people. Now let's examine the number that creates most of the excitement: 71%. In the frequently quoted study, researchers followed non-diabetic adults who had metabolic syndrome. They compared participants with higher dietary magnesium intake against those consuming less. The people in the highest magnesium intake group had approximately 71% lower odds of developing elevated insulin resistance than those in the lowest group. That sounds enormous, but listen carefully to what the study did not prove. It did not give everyone a 480 milligram supplement. It did not demonstrate that insulin resistance fell by 71% inside each person, and it did not prove magnesium alone caused the difference. The participants were getting magnesium through their overall diets. People consuming more magnesium may also have been eating more fiber, seeds, beans, vegetables, and other nutrient-dense foods. Those dietary differences can affect insulin sensitivity independently of magnesium. So the 71% finding is important, but it is an association, not a guaranteed treatment result. It tells us that magnesium-rich eating patterns may accompany better metabolic health. It does not give us permission to turn one observation into a miracle pill advertisement. The next question is more useful. What happens when researchers actually give magnesium supplements and compare them with a placebo? This is where the evidence becomes mixed. One older randomized, double-blind trial studied non-diabetic people who had insulin resistance and low magnesium levels. After receiving magnesium, participants showed a meaningful improvement in insulin sensitivity compared with the placebo group. That trial supports the idea that correcting inadequate magnesium may help when a genuine shortfall is present. But not every trial has repeated that success. A newer systematic review examining randomized trials in people with diabetes or prediabetes found no statistically significant overall improvement in insulin or HOMA-IR. The researchers concluded that any effect may depend partly on a person's baseline insulin resistance, and that larger, better targeted studies are still needed. Then came another important 2026 trial. Researchers studied older adults with prediabetes who also had low magnesium. Participants received 360 milligrams of elemental magnesium oxide each day, or a placebo, for 4 months. Magnesium levels improved, and fasting glucose fell modestly. But the supplement did not significantly improve HbA1c insulin levels or the measurement of insulin resistance after statistical adjustment. And that is a crucial finding. Even in older adults who had both prediabetes and low magnesium, correcting magnesium did not suddenly reverse the entire metabolic condition. It helped one marker, but not all of them. This is why the honest conclusion is not magnesium reverses insulin resistance. The honest conclusion is magnesium may improve certain glucose-related outcomes in selected people, particularly when intake or magnesium status is inadequate. But the results are inconsistent and it should not be treated as a cure. So how do you know whether you may be running low? You cannot diagnose magnesium inadequacy from a YouTube symptom list. Muscle cramps, weakness, fatigue, tingling, poor appetite, and abnormal heart rhythms can occur with significant magnesium deficiency. But these symptoms are not specific. A leg cramp could result from dehydration, muscle strain, nerve problems, circulation issues, medication effects, or several other causes. Fatigue could have dozens of explanations, and palpitations should never automatically be blamed on a vitamin or mineral problem. They may require proper medical evaluation, particularly if they are new, frequent, prolonged, or accompanied by chest discomfort, breathlessness, fainting, or dizziness. Instead of guessing from symptoms, look at the risk factors. Older adults are more likely to consume inadequate magnesium than younger adults. Magnesium absorption can decrease with age, while kidney losses may increase. People with type 2 diabetes may lose additional magnesium through urine. Certain gastrointestinal conditions can interfere with absorption. Long-term use of some proton pump inhibitor drugs for acid reflux can reduce magnesium levels. Certain diuretics can also increase magnesium loss. So a person over 60 who has diabetes, eats a limited diet, takes a long-term acid-reducing medicine, and uses a diuretic deserves more attention than a healthy person with a varied diet and no relevant medical conditions. But testing magnesium is not as simple as many videos make it sound. Most magnesium in your body is stored inside cells or in bone. Less than 1% is found in the blood. That means a standard serum magnesium test can identify clear low or high levels, but a normal result does not always provide a complete picture of total body magnesium status. There is no single perfect test. A clinician may need to combine your blood results with your diet, kidney function, medications, symptoms, and medical history. That may sound less satisfying than one definitive number, but it is far safer than diagnosing yourself from an eyelid twitch. Now comes the most practical part, food. Before worrying about expensive supplement forms, examine what you eat during an ordinary week. For adults over 50, the recommended total daily magnesium intake is approximately 420 milligrams for men and 320 milligrams for women. That total includes magnesium from food, drinks, and supplements, and many people can move much closer to those amounts without taking a large pill. 1 ounce of roasted pumpkin seeds contains approximately 156 milligrams. 1 ounce of chia seeds contains around 111 milligrams. 1 ounce of almonds provides about 80 milligrams. Half a cup of cooked spinach contains approximately 78 milligrams. An ounce of cashews provides around 74 milligrams. Half a cup of black beans adds approximately 60 milligrams. These foods do more than supply magnesium. They also provide combinations of fiber, protein, healthy fats, and other micronutrients that may support metabolic health. Consider what could happen with a few simple changes. Add a spoonful of seeds to breakfast. Include beans with lunch. Eat a portion of leafy greens with dinner. Choose nuts instead of cookies or chips for a snack. that may increase magnesium intake while simultaneously improving the overall quality of your diet. And unlike a pill, these foods are not pretending to solve insulin resistance through one isolated nutrient. But suppose your diet still falls short, or your clinician believes supplementation is appropriate. This is where you must forget the idea that 480 milligrams is automatically the correct amount. The recommended intake and the supplemental upper limit are not the same thing. The recommended daily intake includes magnesium from all sources, but the established upper limit for magnesium from supplements and medications is 350 milligrams per day for adults. Magnesium naturally present in food is not included in that limit. Why is the supplemental limit lower? Primarily because larger supplemental amounts commonly cause diarrhea, nausea, and abdominal cramping. And under medical supervision, clinicians may sometimes use amounts above that limit for specific reasons. But a research dose is not automatically a safe self-treatment dose, so do not look at a study that used 360, 400, or 480 milligrams and assume that you should copy it. The participants may have been selected according to strict criteria. Their kidney function may have been checked. Their medical conditions and medications may have been reviewed, and they were being observed by researchers. That is completely different from buying a bottle online and experimenting on yourself. There is also one label detail that confuses many buyers. The number that matters is elemental magnesium. A supplement might display a much larger amount for the entire magnesium compound on the front of the bottle. But the supplement facts panel should tell you how much actual elemental magnesium the serving provides. That is the number you use when judging your dose. Next comes the question everyone asks: which form is best? There is no single form proven to reverse insulin resistance. Different forms vary in absorption, tolerability, price, and laxative effect. Forms that dissolve well in liquid generally tend to be absorbed more completely. Research cited by the National Institutes of Health suggests that magnesium citrate, chloride, lactate, and aspartate tend to be more bioavailable than magnesium oxide and magnesium sulfate. Magnesium oxide is inexpensive and commonly sold, but a smaller fraction may be absorbed, and it may produce gastrointestinal effects in some people. However, that does not mean every person needs the most fashionable or expensive form. A supplement that looks impressive on social media is useless if the dose is inappropriate. It interacts with your medication, or your kidneys cannot clear it. Choose the product only after deciding whether you need a supplement at all. And now we reach the most important safety check in this entire video. Your kidneys remove excess magnesium from your body. When kidney function is healthy, excess magnesium is generally excreted. But when kidney function is significantly impaired, magnesium can accumulate at very high levels. Magnesium toxicity can cause severe weakness, dangerously low blood pressure, breathing problems, abnormal heart rhythms, and even cardiac arrest. The risk increases when the kidneys cannot effectively eliminate the mineral. This warning matters especially for older adults because chronic kidney disease becomes more common with age and may exist before a person notices obvious symptoms. Diabetes and long-term high blood pressure, the same conditions commonly associated with insulin resistance, are also major reasons that kidney function may decline. So before taking a high-dose magnesium supplement, find out whether you have recent kidney function results. You may see measurements such as creatinine, an estimated glomerular filtration rate, often written as eGFR, in your medical record. Do not attempt to interpret one number in isolation. Ask your clinician or pharmacist whether your kidney function and medical history make magnesium supplementation appropriate. This is not fear-mongering. It is the difference between targeted nutrition and reckless supplementation. Medication timing matters too. Magnesium can reduce the absorption of some osteoporosis medications known as bisphosphonates. It can also bind with certain tetracycline and quinolone antibiotics, preventing the body from absorbing the medication properly. The exact spacing depends on the drug. For example, some antibiotics may need to be taken at least 2 hours before or 4 to 6 hours after magnesium. Do not guess. Show your pharmacist every supplement and medication you take and ask for a specific schedule. Also remember that some medications can change magnesium status. Loop and thiazide diuretics may increase magnesium loss, while potassium-sparing diuretics may reduce magnesium excretion. Long-term proton pump inhibitor use can occasionally produce low magnesium levels. That does not mean you should stop any medication. It means your clinician may need to consider the medication when evaluating your magnesium intake and laboratory results. Now let's step back. Even when magnesium is inadequate, correcting it is only one part of improving insulin resistance. Muscle activity has an immediate and powerful effect on glucose handling. A short walk after a meal allows active muscles to use more circulating glucose. Regular resistance training helps preserve or rebuild muscle tissue, giving the body more capacity to store and use glucose. Improving sleep matters because repeated sleep deprivation can worsen metabolic regulation. Reducing heavily refined carbohydrates and adding protein, fiber, and minimally processed foods can reduce the size and speed of post-meal glucose rises. Losing even a modest amount of excess body fat can improve insulin sensitivity in many people. These actions are not as easy to sell as a bottle, but they have a broader effect because they address multiple drivers of insulin resistance at the same time. Magnesium should be viewed as nutritional support, not as a replacement for movement, balanced eating, weight management, sleep, prescribed medication, or professional care. And never stop or reduce diabetes medication because you began taking magnesium. If magnesium improves your glucose readings while you are using glucose-lowering medication, your clinician may need to monitor you and decide whether any treatment adjustment is appropriate. That decision does not belong to a supplement company, a YouTube host, or the person behind the counter at a health food store. It belongs to the healthcare professional managing your treatment. So let's put everything into a simple decision process. First, examine your diet. Are magnesium-rich foods appearing regularly, or is your diet dominated by refined grains, packaged snacks, and small portions of nutrient-poor foods? Second, look at your risk factors. Are you over 60? Do you have diabetes, prediabetes, gastrointestinal disease, or a limited appetite? Do you take a diuretic or long-term acid-reducing medicine? Third, review your medical information. Do you know your kidney function? Have your medications been checked for interactions? Has your clinician evaluated whether a magnesium test would add useful information? Fourth, use food as the foundation. A handful of seeds, a serving of beans, leafy greens, nuts, or whole grains can increase magnesium without turning one mineral into a medical experiment. And fifth, only add a supplement when the dose, form, and timing make sense for your individual situation. Do not chase 480 milligrams because it appeared in a headline. Do not expect a 71% reversal, and do not dismiss magnesium completely just because it is not a miracle. The real value of magnesium is more precise than that. For a person whose intake is inadequate, correcting the shortfall may support normal glucose metabolism and could improve certain metabolic measurements. For someone who already receives enough, adding more may provide no meaningful benefit. And for someone with impaired kidney function or important medication interactions, an unnecessary high dose may create harm. That is the conclusion the evidence actually supports, not a cure. It supports energy production, normal nerve and muscle function, blood pressure regulation, and blood glucose control. Inside the insulin signaling pathway, magnesium helps enzymes perform the chemical reactions that allow insulin's message to travel through the cell. That gives researchers a biologically plausible reason to investigate whether low magnesium could contribute to poorer insulin sensitivity. And there's another connection. People with insulin resistance or type 2 diabetes can lose more magnesium through their urine, particularly when glucose levels are elevated. That creates a possible two-way relationship. Poor glucose control may increase magnesium loss, while inadequate magnesium may interfere with normal glucose metabolism. However, possible relationship does not mean magnesium deficiency is causing every case of insulin resistance. It means magnesium may be one piece of the problem in certain people. Now let's examine the number that creates most of the excitement. 71%. In the frequently quoted study, Researchers followed non-diabetic adults who had metabolic syndrome. They compared participants with higher dietary magnesium intake against those consuming less. The people in the highest magnesium intake group had approximately 71% lower odds of developing elevated insulin resistance than those in the lowest group. That sounds enormous, but listen carefully to what the study did not prove. It did not give everyone a 480 milligram supplement. It did not demonstrate that insulin resistance fell by 71% inside each person, and it did not prove magnesium alone caused the difference. The participants were getting magnesium through their overall diets. People consuming more magnesium may also have been eating more fiber, seeds, beans, vegetables, and other nutrient-dense foods. Those dietary differences can affect insulin sensitivity independently of magnesium.